Hey, welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board certified neurologist and fellowship trained multiple sclerosis specialist. My mission is to engage, educate, and empower those impacted by chronic neurologic conditions to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things brain health, wellness, self-advocacy, and how to care for your loved ones who are impacted by chronic neurologic conditions. Join me and my super friends and special guests as we get ready for the next episode. And most importantly, let's get nerdy. Hey, welcome to Brain Chat. Oh my gosh, it's so amazing to be here for another episode of Brain Chat. And I have got one of my amazing super friends, Dr. Jakai McEwen, with us today. And we are going to be talking about all things treatment for MS. Welcome, Dr. McEwen. We know that you're no stranger to Brain Chat, but welcome back.
Thank you so much. Thank you for having me. I'm glad to be back.
Absolutely. All right. So, there's been a lot of talk. I spent a great time chatting a couple of weeks ago with Dr. Maima Akinsanya about changes and updates to the diagnostic criteria, how we're diagnosing MS. And so, what better way to kind of continue that conversation than to talk about how we treat it, right? Because if we're going to diagnose it, it's hopefully because we want to do something about it. So, let's first get started. Tell us a little bit about how you became a neuroimmunologist. And we are so excited. You are a neurologist now at the Joy Life Wellness Center. Yes, in Atlanta, Georgia. Yay! All right. So tell us a little bit about yourself and tell us how you got into neuroimmunology.
Absolutely. So, hi again, everyone that's tuned in today. As she said, I am a fellowship trained MS specialist or neuroimmunologist. My joy, or not my joy, but my joy, but my journey to where I am today kind of started as a child. So, I always wanted to be a doctor, wanted to be a pediatrician. And then
Me
fast
too.
forward to
Me too. I want to be a
you did.
pediatrician.
I feel like everyone kind of starts there. You want
Yeah.
to be a pediatrician. For me, it was because my pediatrician was a Black woman. So I'm like,
Mhm.
oh, this is what we do. I can do
Yeah.
this too. And I
Yeah.
loved her. She had to kick me out when I was 22 because I just I wanted to keep going to her.
Mhm.
But I got introduced to neurology when I was in high school. I did a summer program at Emory where I learned about neuroscience and the research aspects of things. So I decided I want to be a pediatric neurologist, majored in it in college. But then when it came time to apply for med school, I got imposter syndrome. And
Mm.
I thought that I was going to be told no. I didn't want to be told no. I thought my scores weren't good enough. So
Mm.
I decided to take a step back and I went to grad school instead to get my master's. But on my first day of school, of grad school, I woke up with blurry vision in my left eye.
Mm.
That blurry vision led to a diagnosis of optic neuritis, which
Mm.
then led to a diagnosis of multiple sclerosis.
Mm.
So at that time, I knew nothing about MS. I threw myself into everything MS. I did my thesis in grad school on MS. I interned with the National MS Society and decided that what are the odds of me trying to get away from medicine and then boom, I get diagnosed with this neurologic condition. And I was already interested in neurology.
Yeah.
This is what I'm meant to do.
Yeah.
There are no coincidences.
Mhm.
So I went ahead and applied for med school, got into medical school, continued to be interested in neurology. And
Mhm.
because of my personal history, I decided to do a fellowship in neuroimmunology. So
Yeah.
kind of a roundabout way that really wasn't roundabout because it was meant to
Yeah.
happen. But
Yeah.
I'm here now working with you.
And we're so glad you are helping the people. That is amazing, And so, I always love talking with you, Dr. McEwen, because you have both the neurologist perspective, but you
Mhm.
also have the patient perspective. So it's very unique that somebody is working in the field with the condition they have. So you literally
Right.
understand what the patients are going through, but you also
Mhm.
understand the science. So, my nerdy brain is like, this is so
Right.
cool. All right. So let's talk a little bit about treatment. So this one I wanted to focus on treatment, not necessarily on specific medications, but let's just take the 50,000 foot view. So
Mhm.
many people, when they're first diagnosed, obviously there's kind of the shock, like, how did I get MS or why did I get it? Did I do
Right.
something to get it? Which, of course, we know that they didn't do anything to get it. But then I think the next question, when people start to do research they come to the doctor. One of the first things people say is, Dr. Mitzi, there's no cure. And of course, I always say, well, name me 5 diseases that there is a cure for, right?
Right.
Well, people can't. But at the same time, it's like, well, if there's no cure, and if I'm looking at these studies and they say the medicine only works 60% or 40%, then
Mhm.
why should I start a treatment? So let's just start there.
Mhm.
Why should people consider taking a disease modifying therapy if they are diagnosed with MS?
Absolutely. And I think this conversation is very important. And you'd be
Yeah.
surprised that a lot of people that I see, whether they're coming to me for a second opinion or they're newly diagnosed, don't understand, I guess, the underlying kind of mechanisms of how MS works and
Hmm.
then how that goes into why treatment is so important.
Yeah.
So, as you said, there's not a cure for MS, but now we have amazing medications that can
Mhm.
actually help slow down the progression of MS. It can help prevent new relapses, it can help prevent new symptoms if we're able to slow things down early enough. And I think that's the importance of going on a medication. We have these goals that I always talk to my patients about. And the first one is, of course, we want to reduce relapses.
Right.
I don't want you to have any new symptoms. I don't want to see any new lesions on your MRI or in your brain or in your spinal cord, because we know that what we are treating today is what we want to treat 50 years down the line. We
Yeah.
want your brain to predict how you're going to act and how you're going to be when you're 60, 70, 80 years old.
Yeah.
So that's one important thing to help treat those relapses, to help slow down the progression. Also, medications can help with management. And then I think the biggest thing is quality of life. We know that
Mhm.
our medications, whether we're talking about a disease modifying therapy or symptom management, all of it is going to help improve quality of life.
Absolutely. Right. And I think, again, it's important to recognize that the way we treat MS is a little bit different than how we treat other diseases because the treatments are really preventative, right? So
Mhm.
oftentimes when someone is diagnosed with diabetes and their sugar or glucose is high, we can give medicines and immediately see that glucose come down. Or if someone has symptoms from high glucose, we can see those symptoms change. But with MS, the
Mhm.
medicines that we give specifically for the disease don't affect the symptoms that you have now. So I
Right.
always say we can't fix what's already broken, but our
Mhm.
goal is to try to prevent new things from being broken. And so that factors into quality of life because we don't want to
Mhm.
add anything else on top of what we already got going on. And
Exactly.
ideally, we want to catch you as early as possible or as close
Mhm.
to normal neurologic functioning as possible and keep you that way. So, in
Mhm.
that vein, let's think about what is the best, or let's talk about what's the best time for people to start treatment. So sometimes people
Mhm.
come in the office and they say, hey, Dr. Mitzi, I want to try exercise and diet, which we want people to do that on top of the
Mhm.
medicine, right? But they say, I want to try exercise and diet and see how I do. And then let's try treatment later. So,
Mhm.
what is the best time for people to consider starting therapy?
Personally, and I guess academically, I feel that the perfect time is as early as possible. Just like we want to be able to diagnose someone early, so there have been changes to the diagnostic criteria over the past couple of years and more recent changes this past year to allow for earlier diagnosis. And with that early diagnosis, I think gives us that opportunity where we can treat early. I definitely kind of put an urgency on earlier treatment, especially if I see, say, lesions in the spinal cord. Not that lesions in the brain aren't just as scary, but the brain is much larger, so we have more of a reserve there. So sometimes we can have asymptomatic lesions, or basically lesions that don't cause any symptoms. Not saying that as we get older and our brain naturally shrinks, that these lesions won't cause the symptoms earlier or later in life. But the scary part with a spinal cord lesion is that we just never know. The spinal cord is a lot smaller, and we're
Mhm.
more likely to have symptoms if there's something in the cord. And just like we've been talking about, we want to prevent these things from happening, and we have the capability to hopefully do that. So I think as early as possible on some type of treatment, I think the better.
Yeah, and the research is consistent with showing that, we used to have graphs of what we call the natural history of MS. So I think that,
Mhm.
again, if we started with the 50,000 foot view, let's maybe take the million foot view.
Mhm.
MS is a disease we've known about since the 1800s. We did not
Mhm.
have any FDA approved treatments for MS until 1993. Like I
Right.
was in high school. Don't age me. But,
Right.
I was fully able to know what was going on in the
Right.
90s, right? So we didn't have any treatments until 1993. And then we've really seen this kind of revolution in the way
Mhm.
that we've been able to treat MS just over the past 20 to 30 years. And
Mhm.
so what we have is these old graphs because we didn't have anything we could do. And we know that people become significantly disabled without any treatment. And
Right.
we have seen those same graphs plotted with people who do early treatment, like right after
Mhm.
diagnosis, and late treatment. And what we know is that the people who have the least disability typically are those who start treatment early. You do better than if you did nothing if you start late, but you do better if you start early. And if you start late, you never really catch up with what
Mhm.
could have been your level of functioning if you started early. I think something else really important that you pointed out was about the lesions, right? So even if
Mhm.
you're not having symptoms, you can develop lesions, and we don't want to see those because if they don't cause you trouble now, it doesn't mean they can't cause you trouble
Mhm.
a little bit later on in life. So I think those are really important things to underscore. Now, let's talk about the decision making process, right? So you're saying, hey, Dr. Mitzi, hey, Dr. Jakai, okay, you want me to go in, you
Mhm.
want me to start this treatment. When we say urgent, I think it's important to recognize that we want people to start treatment quickly, but it doesn't have to be like today, right? The
Right.
process is
Right.
going to take a couple weeks. So
Right.
there is this shared decision making process where you can sit down with your doctor. I give people
Mhm.
homework, go home, I give them websites to look at. We narrow it down to a couple of treatments. You go
Mhm.
home, do your research. We come back and have a conversation in a week, right? And so sometimes there's not the capability to do that depending on your doctor's availability. But let's talk about what does shared decision making mean to you and what does that look like in the real world?
Shared decision making, I think we can easily just explain as allowing patients to have a seat at the table.
Yes.
At the end of the day, the way that we are managing an individual's MS is purely or should be purely based off of that person.
Hmm.
There's so many different factors that go into deciding what's going to be the best option in regard to management of their
Hmm.
disease.
Hmm.
And so I always like to lay out the platform and start off with making sure that my patients are aware of what we're expecting to see with a say disease modifying therapy. So we're not. I don't want them to think that we're going into this, like you said earlier, magically resolving lesions or getting rid of symptoms that they already have, but again that we want to focus on their future selves and we want to prevent or reduce new lesions, new physical symptoms and things of that nature. And then more importantly, what and having a discussion about what are the things that are important to you. What are
Hmm.
your goals?
Yes.
What do you want to focus on? Of course, as a neurologist, I may know what your brain and your spinal cord looks like and what your labs look like, but that doesn't mean that I know you. I don't know your home life. I don't know your if you have a car that it gets you to and from infusion centers. I don't know those things without us having those open dialogues and those conversations. So I always like to start there to, I guess, build a rapport and
Yeah.
know them a little bit more, and that allows me to better guide the conversation on which medications I think would best fit them.
Yeah, and I love that because it was not that way when I first started practicing. It was very much this is what you're gonna do, this is what we
Right.
got, and then,
That was all that was there.
we
Yeah.
will be surprised when people came back and were like, I'm not taking that. And you're like, what you mean? So I think that, it's so important for us to bring the patient voice to the forefront and sit down and discuss, okay, what are your goals?
Yes.
Help to kind of modulate them
Mm-hmm.
and hopefully give a little bit of realistic expectation because sometimes your goal may be to run a marathon and I'd be like, well, I don't know about that. Or I may be, yeah, we can do it. So I think that we sit down and talk about those things. You mentioned something earlier about factors that we take into consideration
Mm-hmm.
when talking about or deciding on treatment. What are some of those factors, for those
Mm-hmm.
who are listening?
I'll use myself as an example. One factor could be just lifestyle.
Mhm.
For me, when I was first diagnosed, I was started on an injectable. I'll just say the best medication is the one that you will take.
That's it. That's
I was
it.
not a good patient. I did not take my medicine. I didn't like the injections, me personally. And then I was surprised when I had new lesions on my brain that were
Mhm.
active. You weren't taking your medicine, Jakai.
Right.
So, that's one thing. But then also, kind of a little bit later, as some of the newer options came out, I'll speak a little bit about the infusions. I was presented with two options. One was monthly, and another one was to do twice a year. At this point, I was in residency, and so my time was not my own, and so
Correct.
I did not have the means to kind of schedule around getting a monthly infusion. No matter how short the infusion was, I wasn't able to do that. So for me
Mhm.
personally, and with my lifestyle, taking one day twice a year worked better for me.
Yeah.
So that's one thing that I look at is lifestyle. What are you close to an infusion center? If not,
Mhm.
would doing an injection at home or taking a pill at home be better for you?
Mhm.
Other things we want to look at are comorbidities. So
Yeah.
looking at other symptom, or excuse me, other, what word am I trying to use? Help me
Diseases
out.
or other conditions, medical conditions.
Conditions.
Yeah.
Thank you.
Yeah.
Other
Yeah.
medical conditions that you may have. So if someone has another type of autoimmune condition that might affect their immune system, or if they're on another medication for that, maybe say a rheumatologic condition that might affect their immune system, we might not want to put them on a medication that will further reduce their immune system or cause
Mhm.
additional issues. So we
Mhm.
look at all of those things when it comes down to helping figure out what would be the best options.
Absolutely. And then we also look at, and you touched on this, prognostic factors, right? Are there
Yes.
things, of course, I tell people my crystal ball is in the shop, and when I get it out, I'll let you know how you're going to do in 10 years. So we can't predict exactly how any individual will do, but there are some factors that make us a little bit more concerned that your disease may be a little bit more aggressive. And that's if you have lesions or damage to your spinal cord or that bottom part of your brain, the brainstem. If you have a lot of inflammation or activity on your MRI, new activity like lighting up with contrast. We look at things like age. We look at things like if your first symptom was difficulty walking. We
Right.
look at, unfortunately, the men may do a little bit worse. And so we look at all of these things and we sit down and have that conversation. And when we look at medications, we look at the side effects. We look at how it's given. We look at, again, will it interact with any of your other medicines? And then
Mhm.
factor in that lifestyle. And then voila, we come up with the individualized plan for you.
Right.
So it's not a perfect system, but I am very excited that we are all becoming more conscious of putting the patient voice at the forefront and
Right.
asking people, if I'm talking to somebody and I say the
Mhm.
word needle and they start crying, then that's
Right.
probably not for them. You know what I
Mhm.
mean? So,
Mhm.
there's
Yeah.
simple things like that. And I think it's encouraging people to advocate for themselves and be active
Yes.
parts of their healthcare team, right? Because you
Most
have a
definitely.
say and
Mhm.
you are more likely to follow through with something that you had some say in versus
Right.
somebody just telling you what to do and expecting you to go home and do
And
it.
understanding how the medication works, I feel like
Yes.
it's really important to educate just in general. What is MS? What are things that I can expect? Does it,
Hmm.
or what are things that I might want to relate to MS, because we know everything is not MS related. Um,
Absolutely.
then how is my medication going to work, and what are the possible side effects that I could look out with? And again, that helps with the patient physician relationship, so
Yeah.
that we know best how to help you. If you know things to look out for or what to expect with the medication, then it allows for us to better guide you.
Yeah. And I oftentimes will have a visit where we will talk about treatment options.
Mhm.
And then I'll have someone go home, do some homework, do some research, and then come back, ask me whatever questions we want to
Mhm.
ask if we need to clarify, and then we make a decision because
Right.
sometimes people feel rushed if we do it all in one day. I remember when I could talk to people about all the treatments in one visit. I could diagnose, talk about treatments, pick a treatment, do all that in one visit, right?
Mhm.
But I think it's important for people to have that time to digest, see
Right.
what questions they have, and then we just have another question. And I think that treatment is a every visit conversation. How's it
Absolutely.
going? Are we having any issues? Am I
Right.
having any issues taking it? Is this
Right.
still the right thing to do? And so that's something I think people should talk about at every visit. Um,
Right.
thinking about, picking a treatment. So let's say you went to the doctor after your diagnosis, you had that
Mhm.
visit, you did your homework, you picked your treatment. Let's talk about what success looks like. What does success looks like? Because I can't tell you how many times I have a conversation and I say, it's not gonna fix what's already broken. And then when we do that 3 month visit, they're like, but my leg ain't better. And I'm like, I ain't tell you your leg was gonna be better. So what does success look like for disease modifying therapy?
I think success for disease modifying therapy has changed over time.
It
It's
has.
changed as we've gotten newer and I'll just say better medications, high
Mhm.
efficacy medications that we know we have the data to prove that they work extremely well with
Mhm.
slowing down the progression. In some cases where we're not seeing any evidence of disease progression in both clinical, so where people are not having any new symptoms that
Mhm.
they're showing, as well as when we're
Mhm.
looking at MRIs where we're not seeing any new lesions or on the brain or the spinal cord. So honestly, that's what I look at. At
Mhm.
this age, our medications work so well is that I think that we can achieve that. So that's my ultimate goal is to see no new lesions on imaging and no new clinical symptoms. And then yeah, major kind of mainly starting there, I think.
Yeah. So I say steady Freddy. If you come back to me
That's
in three
great.
months, 6 months, and you say, I feel the same, I'm going to do a happy dance. If you say,
Yes.
Dr. Mitzi, I'm going downhill, we're going to have a
Right.
problem. If you
Right.
say you're better, that's great, but that's not what the medication is
Right.
approved to do. Oftentimes, when we're able to treat the inflammation and get that under control, your
Mm-hmm.
body does have a chance to heal itself to a certain
Mm-hmm.
extent. But that level of healing and improvement is going to be different for each person, and it's not something that we can really predict. But if we
Mm-hmm.
can get the process under control, then that gives us a better chance to
Mm-hmm.
let your body heal and kind of see where you wind up. So if we see improvement, great. But
Mm-hmm.
our goal is stability, for you
That's
not to
right.
come back and say, I'm doing a whole lot worse.
That's right.
And so when we are having these conversations, I think it's
Mm-hmm.
also important. And what I try to explain to my patients is how we've changed kind of our approach to treatment. So let's pause for a second and talk about escalation therapy versus high efficacy therapy. What does that
Mm-hmm.
mean? So it's a buzzword at all of our conferences.
Mm-hmm.
Patients may see it in some of the literature, depending on what they're reading. What does that mean?
So the classic way of treating or approaching treatment to MS was with escalation therapy. So
Mhm.
you would start on a medication that maybe wasn't as efficacious as another medication, but it was safer.
Mhm.
And we were like, okay, well, we'll just start here. And then if someone has breakthrough, meaning a new lesion or new clinical symptoms, then move up to a different medication. But now we know from data that just how we mentioned earlier, the sooner we're able to get someone on a medication that is that works better, the least likely we are to go on to have further disease activity. And so that's our goal. Again, stability is our goal. So why do we want to just wait to see something happen?
Right.
So now it's shifted more towards where majority of neurologists and MS treating specialists will treat with high efficacy therapy out the gate. So we're going to start with the best medications that we have with the goals of kind of shutting things down right away versus kind of taking a wait and see approach.
Yeah, absolutely. And, at the end of the day, there is data that shows that starting higher efficacy or more
Mm-hmm.
effective therapies earlier does seem to impact the overall course of disease. But
Right.
there are several large clinical trials that are looking at this very thing to
Mm-hmm.
give us more definitive answers about what is the best way. At the end of the
Mm-hmm.
day, depending on the person, even if somebody does start a lower efficacy therapy, it's important to follow up with your neurologist, with your treatment team, so that if there are any signs that anything is changing or different, then that therapy is escalated. But yes, absolutely, many of us do use high efficacy therapy. And let's
Mm-hmm.
kind of talk for a few seconds just about the different types of therapy. So when I started, we had what we called our ABCR drugs, which were our traditional injections. There was a group called interferons, and then there was another class, gluteramine acetate, which there's several. That's one drug, but there's several different, brands within that. within that category. And then we
Mhm.
had natalizumab, which is an infusion
Mhm.
medicine. So that was out when I
Right.
finished my training. And then we also had a drug called Novantrone, which we don't use very much
Mhm.
anymore. And Novantrone was an IV chemotherapy that we gave every 3 months, but we don't use it as much anymore because it
Yes.
could cause leukemia in some people
Right.
and it could cause heart issues. It was really high
Mhm.
maintenance. But at the time, that's what we had and that's what we
Right.
were working with. Tell us about how far we've come since then. So I saw the first pill come to market, which was a big deal because we did not have any pills when I started. But we've seen
Right.
several oral therapies come to market. And tell
Yes.
us a little bit about some of our other higher efficacy class medications.
Yes, absolutely. So I feel like I still can see a little bit of the progression of where we've gone with the disease
Yeah.
modifying therapy. So I was diagnosed in 2009. So
Mhm.
at that time, there was buzz about a pill coming out. And,
Yeah.
I wasn't a doctor then. And so I was like, oh, a new medicine. I don't want to go. I'm not going on that. Something new. It has to be out long enough. Don't even talk to me about that.
Right. Don't give me the new stuff.
Right. No, I wanted the new stuff.
Uh-huh.
But the with the first pill coming out in 2010, and then at times, so with the oral medications, we have the fumarates, we have SP1s, we have a lot of different oral medications, even a fancy one, how I kind of explain it to my patients, where you just
Mhm.
take it for 2 years and
Mhm.
and then that's it. And then we have some of the newer infusions. So we already talked about natalizumab, but we also have the anti CD20s or the anti B cell medications
Mhm.
that came out and also helped to change the game in regard to management for
Mhm.
MS. So I think it brings a lot of different options.
Mhm.
Where again, if someone doesn't want to physically inject themselves, they can choose an oral agent, or go somewhere where someone does the infusion for them.
Hmm. Yeah, and I think something else, and we can get not too deep in the weeds, but I think this
Mhm,
is important, is that when we talk about how we treat MS, what we're trying to
mhm.
do is modify the immune system. And we have a couple of different ways that we do that. So, our traditional drugs, the ones that first came out, our injections, we kind of think of those more as immune modulators. So, I think of that as
Mhm,
kind of tweaking the immune system so that ultimately we have less inflammation and more products or cells that are anti-inflammatory. So we kind of
mhm,
tweak it a little bit. Then we have our depleting therapies,
mhm,
where we actually kill stuff, right? And so, of
mhm,
course, whenever we kill stuff, there are consequences. But we kill things, we let them grow back, and then we kill them again, right?
mhm.
Now, when we're talking about depleting therapies, even though in some cases people would put them in a category of like chemotherapy, we're not giving people doses of medication to the same degree you would get if you had a cancer, right? Because our objective with MS is different. We're not trying to wipe out your whole immune system.
Mhm,
We're just trying to knock it down a little bit because your immune
mhm,
system is doing the most. And then we also have what we call repopulation therapy. So those are therapies where we kill everything, let it grow back. We might kill it one more time, let it grow back, and then we see how you do. And so those are shorter course therapies where you may take it for 1 or 2 cycles, let's say for 2 years, and then hopefully you may not need it again, or
mhm.
you may not need it until 4 or 5 years later. And so the way that we treat MS has changed drastically over these years, but the objective is to knock down your immune system.
Right.
And it's important to recognize that having MS itself does not mean your immune system is compromised. Your immune
Uh-huh.
system is doing the most. It's dysregulated. It's
Right.
not doing what it's supposed to do. It's doing some of what it's supposed to do and it's doing some extra stuff. So I had patients come in, they're like, oh my God, this is going to suppress my immune system. I'm like, that's what we want to do. We want to suppress it because it's doing too much, right? We want it to do less, right? We don't
Right.
want it to do so little that it makes you sick, but we want it to
Mhm.
do it less so that it's not attacking you. Anything
Right.
you want to add to that?
And I think with that, that's also why it's so important for us to know other conditions or medical
Yes.
conditions that someone has. So that plays a role with deciding or helping you to decide the medication that we ultimately start you on. So if someone comes in and you have recurrent pneumonia, or you're having recurrent urinary tract infections or any other kind of infection, recurrent sinus infections, we might not want to give you a medication that is going to further suppress your immune system and prevent your body from being able to attack those and help you heal from it. So all of that plays a role.
Absolutely. Absolutely. And so, what are some of the most common side effects that we see with some of our medications, right? I have a lot of people that
Mhm.
say, Dr. Mitzi, I was good. And then I went home and I started reading them side effects and I got scared. Let's talk about side effects.
Yeah, so I guess we can start with kind of our platform. So our
Hmm.
ABCs. So we're there. We don't use them as often, but there are people that are still taking those medications, and if it's working for you, I'm not going to rock the boat.
Right.
But common side effects that we can see with those are like flu-like symptoms.
Hmm.
Others sometimes we need to monitor closely, like liver function, even
Hmm.
thyroid.
Hmm.
So I mentioned I was on an injectable when I first got diagnosed, and ended up having to come off of the one that I was on, the first one that I was on, because my thyroid hormones were starting to change, and they weren't functioning properly.
Hmm.
So we monitor closely those types of things. With coming into our oral agents, some of those we monitor white blood cell counts,
Hmm.
specifically one that we call lymphocytes or absolute lymphocytes. We want to
Hmm.
monitor those because sometimes they can get lower, and we expect it with one of them. Say with one of the medications, we want them to be kind of just sequestered to the side
Hmm.
in your immune
Hmm.
system, so we'd expect them to be lower.
Hmm.
With some of the other oral agents, we monitor and make sure that they don't get too low, because that can increase your risk for infections again.
Hmm. Hmm.
And then with say natalizumab, one of the criteria that we look at prior to starting that medication is making sure that you haven't been exposed to the John Cunningham virus or JC
Hmm.
virus.
Hmm.
We know that exposure to this virus increases one's risk of getting this brain infection called PML.
Hmm.
So we're able to check for that virus, and we know even have whole tables and titers to know levels, and to able to carefully calculate someone's risk for that. But we monitor that closely when on this medication, again prevent this brain infection. And then with some of the other ones, again, we're monitoring um, kidney function, liver functions. Even if we're not expecting changes there, we just kind of we want to look at it and make sure that those things are okay. So there will be labs that are obtained twice a year, yearly, every 3 months, depending on the medication. Just
Hmm.
again to make sure that we're having what we call good therapeutic drug monitoring.
Hmm. Absolutely. And then with some of our infusions, there is a risk
Mhm.
of infusion reaction, right? And
Yes,
so,
yeah,
because we
yeah.
know that a large percentage of people have those infusion reactions, there are often pre medications that you're given
Mhm.
before the infusion to try to prevent that. And if you still have a reaction, we can always modify or tweak those pre medications or post medications to prevent that reaction. Now, the
Right,
other thing I think is important to recognize is that there are some side effects that are common side effects. There's
right.
some that are serious side effects that aren't very common, because I think
Mhm.
sometimes people, everybody says, Dr. Mitzi, if it's a side effect, I'm going to get it. If it's something weird, I'm going to get it. And I'm like, everybody says that.
Yeah.
But most of the time, it doesn't happen. So I think, when you're having those conversations with your neurologist, when neurologists are having those conversations, it's important to, say, I've got to tell you all the scary stuff. I've
Yeah.
got to tell you what to look out for. But these things very rarely happen. The most common side effects are this, 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 this. And with most of our drugs, upper respiratory infection can be a common side effect, for some infusion reactions or injection reactions. And so we tell you the most common ones, but know that even though we tell you about the scary ones, they're not very common. And
Right,
many of the times, people take the medicine and don't have any side effects or issues,
right.
right? And they come back surprised. I'm like, well, I told you most people don't have anything, but it's my responsibility to tell
Yes.
you about, what is the worst case scenario or what are the worst possible things, so that we can be on the lookout for those and make sure
Mhm.
we don't miss them. So
Absolutely.
that's something else. I'm like, if you read a package insert for a bottle of Tylenol, it'll scare you to death, right?
Right.
And people take it all the time. So again, a difference between common side effects and serious side effects is
Mhm.
extremely important for us to underscore. So the
Yeah.
time is going by so quickly, but let's think for a second. Tell me kind of what tips or advice you would give to somebody who is kind of entering this space, trying to decide what type of treatment they
Mhm.
need, and kind of where to go. What would be the advice you would give to people out there that are listening or watching?
Yeah, so I would say first and foremost, establish care with a neurologist.
Mm-hmm.
Of course, as MS specialists, we love other MS specialists, and we think that everyone should be able to have or see an MS specialist, but we know that's just not the case. Going to be the case for everyone, depending on where you live, what part of the country. But as long as you have a neurologist who's comfortable with multiple sclerosis, that's a great start.
Mm-hmm.
Have the conversations, come in prepared for your appointment so that we know these things. Again, we want to get to know you. We want to know what your lifestyle is like. We want to know what your goals of care, what do you want to see out of your treatment, and then that can help guide or start that conversation with what would be the medication options that are best with you. But coming prepared and ready to bare your soul. I don't know, so we'll tell you if it's too much,
Tell us
but
all the business.
give
We
us
need to know the
everything.
business.
And then we can reel you back in if we need to.
Absolutely. And one thing that I forgot to touch on, right? Because
Mhm.
this is often the most common resistance I have to treatment is, hey, Dr. Missy, what about natural lifestyle? Is there something natural I can do for my MS? Touch on
Right.
that.
So with natural, I have no problem having those discussions. I actually, I would say I promote it, but more so for when we start talking about management of your symptoms. So when we're approaching management of your MS, we're looking at two separate things. So we have our disease modifying therapies, where we're working to slow down the progression of your MS. We're working to prevent new relapses. And then on the other side, we have symptom management. So as we said before, with disease modifying therapies, they are not necessarily going to improve prior symptoms that you already had. We're not, unfortunately, at this point, we're not fixing old damage. So sometimes we need to manage things separately. So that's where I think kind of approaching things more naturally come into play when it comes to managing more symptoms. Um, of course, I cannot tell you what to do. And I will never dismiss someone from my practice because they do not want to go on a disease modifying therapy. But I will always make sure that you understand kind of the thought process behind why we like to separate it.
Yeah.
When it comes to more symptomatic management, that's where in the natural things, I talk about vitamins and I talk about other things like acupuncture and diets. While there aren't any approved diets that's supported by evidence-based data that modifies multiple sclerosis, we know that diets that just in general are good for you. They protect your brain, they protect your heart.
Mhm.
That's going to be what we're going to recommend. And then other things, everyone may have other symptoms that we need to talk about. Fatigue is a huge
Mhm.
thing that we talk about a lot with MS.
Mhm.
And so we have several approaches to that. And it doesn't have to be a medication.
Mhm.
Majority of the time, we might want to approach it looking at your vitamin levels and
Yeah.
doing things more naturally before we have the discussions of a medication.
Yeah, absolutely. And I think lifestyle modification has really come to the forefront in
Mhm.
medicine and science. To be 100% honest, they don't teach us a lot about it in medical school. They teach us a lot about drugs. They don't teach us a lot about lifestyle modification. I think for me, what I try to encourage people to recognize is that we have the best results when we do right?
Mm,
Not a either or. When we add them
yes,
both together, people do really well
yes.
because lifestyle modification, meaning eating a healthy, well balanced diet, whatever that looks like for you. As you
Mhm,
mentioned, isn't there's not a particular I've had people be successful on every kind of diet you can think
mhm.
of. The best diet is one you can stick with long term,
Right.
right? So don't cut out all the foods that taste good and eat grass and then you hungry in 3 months
That's
and you eating
boring.
everything in but grass. Okay. So a healthy balanced diet, exercising. There is
Mhm,
data that exercise helps slow the shrinkage of the brain, and
mhm,
we know that our brains shrink as we age, and we know that shrinking occurs more quickly when we have multiple sclerosis and damage to the
mhm.
brain. Also, sleep. People really, really need to get more sleep because
Yes.
sleep is a process through which your brain is able to clean up all the junk and debris that it accumulates during the day. So just like your kidneys filter, your liver filters, the only
Mhm.
time your brain has enough time to filter is when you sleep. And if you're not sleeping, it's no filtering going on. And so that can lead to accumulation of all kind of products in the brain that can increase the risk for dementia, things like that. So we cannot underscore enough the importance of lifestyle modification, right? So you can't just take the medicine and expect it to do everything for you. There's still work that you have to do. My favorite Dr. Mitzi-ism is, there's a part you play, there's a part medicine plays. There is no medicine that gets rid of the part that you play in your own health. So
Right.
making those healthy changes can not only help your heart, but literally can help your brain and help build up that reserve that helps us to combat injury. And so those things are extremely important. But the best results that we've seen is when you combine that with lifestyle modification with disease
Right.
modifying therapy. Because remember, we had over 100 years, the 1800s to 93. We had a whole bunch of time to see how people did without medicine
Right.
because we didn't have anything. And I'm sure lots of people were exercising and doing everything they knew to do. So we know that in many cases, having both of those works. Now, at the end of the day, if you feel very strongly, you're talking with your doctor, okay, and you don't want to do disease modifying therapy, as you said, Dr. McEwen, you grown,
Mhm.
can't make you do nothing, but just make sure that you're following up regularly so that your doctor can be checking those MRIs. If we see anything that looks like it's new before you have symptoms, then ideally we should be able to catch it, you know. So
Right.
again, don't drop out of the system, you know, but continue to follow up regardless as to what you decide to do. And then we'll continue to monitor with those visits and with those MRIs to help us best understand what the next best step is. So with
Absolutely.
that being said, any parting thoughts, Dr. McEwen?
I would say know that you are at the forefront.
Mm,
I think it's so important to advocate for yourself.
mm-hmm.
Um, no one knows your body better than you do.
That's right.
So learn as much as you can about MS and do your own research. Come prepared to your appointments. Again, tell us more than we want to know because that's the only way that we are able to help. And I know I don't mind sharing that Dr. Mitzi is my doctor as well. And and I come to her and she's very honest with me with some things. I spoke with her about fatigue once and she was like, "Are you sleeping?" I was like, "Well, no, it was anxiety." And she was like, "Well, how's your sleep?" And a lot of different things. And I'm like, I wanted the medicine. I'll be honest with you guys. And she said, "No, let's work on your sleep. Here's the Calm app." So just be upfront and honest with your your neurologist,
Yeah.
and that is the best route to go. I feel like.
Yeah. And I prescribe meditation all the time. I'm like, Sugar, you need to meditate. You need some sleep storage. You need some
And
essential
it
oils.
worked.
And
It
it
worked.
works
I'm putting
if
down
you
the
work it.
medicine.
Every once in a while, Dr. Mitzi is right. But thank you so much, Dr. McEwen, for sharing
Thank
your
you.
valuable expertise from both sides of the table, so to speak. And thank you so much for coming and hang out with us on Brain Chat.
Of
Thank you
course.
to the National MS Society for sponsoring Brain Chat this season. And thank you to all of our viewers and listeners. We'll see you again in 2 weeks.